Okay, good morning all. My name is Vanda Carter. I'm a nurse and FAB ambassador. It's the 6th of April 2022 at 10 o'clock. Welcome to the inaugural FAB talk. These are a series of talks where the guests might not be the usual suspects. They may not be a chief executive, but they do have a story to tell us, and we welcome their story. Today, it's my pleasure to welcome Christine Mimnagh to talk about her work and her journey. So we welcome you, Christine.
With Babylon, my role kind of evolved, and they were looking for how to advance people in their careers, and instituted clinical champion roles. And the clinical champions, basically, if you're passionate about a topic and you want to take a lead on it, then put your hand up and develop. And as a result, I became the clinical champion for gender identity for Babylon. So that's been really interesting. Tell you about how that works at the moment. Back to the NHS practice, COVID hits. And when COVID hit, we didn't change a thing. Honest to God, didn't change a thing. The door stayed open because only people that were coming in were people that we'd talked to on the phone, that we knew what was going on. We opened a hot room around the back, which was literally one door and 4 feet into the consulting room, and we were able to isolate that area. So anybody that was potentially COVID positive came in that way. And that kind of paid off in the eyes of the patients. The patient satisfaction survey every year comes out, and you get that sort of, these are the 3 things you're above average on, doing well. These are the 3 things you could do better on because you're below average on those. This last time, pleased to say and proud to say that we had the 3 things that we're above average on and doing well, or 3 of the things. And then when it comes to the section of where you could do better, it was empty. We had, we were not below average on any in the patient satisfaction survey, which if you trawl the data, it doesn't happen very often, but we're pleased about that. Now, the practice is doing well and that model's working really well. Just in the middle of the pandemic, NHS England found out about the work that a collaboration of us were doing on Merseyside and Cheshire, looking at how to help trans people access good primary care. And that's not as easy as you might think if you happen to be transgender. A colleague of mine was set up as a GP with specialist interest in Sefton, as a service called Trans Health Sefton. And that came about partly because my older brother persuaded all the GPs in the area to not support trans people's prescriptions for gender-affirming hormone therapy. He was the chair of the LMC at the time, and there were some GPs who were rabidly anti-trans, and my elder brother managed to say, well, actually, let's follow their line, and nobody does this. The clinical commissioning group then had a big problem because they've got a problem, they've got to do something about it, and that precipitated the appointment of my colleague Anna Ferguson as the GP with an interest for trans health, and that started in 2017. So when NHS England were looking for pilot sites to do new models of care, we ended up coming on their map by accident, funnily enough, as luck would have it. Obviously, if you look at where gender identity clinics were previously, you might get the idea that being trans is a railway transmissible disease. Because if you think of the first one, started in 1970 in Charing Cross, transness, clearly based in London, then it spread up the East Coast to Daventry, Sheffield, Leeds, Newcastle. So clearly East Coast mainline, transmissible. But then it must have also gone on holiday to Exeter. And that was, for years, decades, the map of gender identity clinics in England. And worse than that, if you were Welsh, you were always contracted to go to Charing Cross in London. So clearly a massive gap on the west side of the Pennines. And if you were looking, as NHS England did, at somewhere to place a service on the west side of the Pennines, Manchester with its Devo Manc, with its Pink Pound, that would obviously be the place. And it's a great conurbation size. And when the commissioners came up to Manchester, colleagues in Manchester said, well, actually, if you think we're doing okay, have a chat with the people down the road in Liverpool, because they've got this going since 2017. So by accident, almost, we ended up getting commissioned as an NHS England pilot site. Slightly delayed in our implementation by COVID, but now we're running. Out of all the pilot sites, and the new pilots are great. There's the Welsh service based in Cardiff, which isn't a pilot; it's the new service. There's Trans Plus, which was the English pilot sites based at Dean Street in London. There's the Indigo service based in Manchester, collaboration between the LGBT Foundation and one of the GP out of hours providers. And there's us as the Cheshire Mersey Area Gender Identity Collaborative. We're the pilot part is run by Mersey Care Trust, which is a big foundation trust, community foundation trust for Merseyside. And the collaborative's the key bit, because, you know, when it comes to being trans, what you really need is care at different levels.
Absolutely.
So if you think about Maslow's hierarchy of needs back in the old days, it started with food and shelter, and now it starts with Wi-Fi. So, you know, that pyramid care, finishing with self-actuation at the top. The proper care and feeding of trans people is also a pyramid. The base of the pyramid is identity. That's, am I trans? What does it mean? Am I trans? Am I trans enough? As Mia Violet put as the title of her book. The next level up is the psychology of it. So what? So what does that mean if I am trans? How does that feel? What do I do to improve my life? Alongside that are the audio visual things that you can do. That are things like speech, vocal coaching, facial hair removal, those kind of things for trans women, and how you present. So, you know, making your identity manifest in reality through non-medical or surgical means, because the next level up is medical and the top level is surgical. Now, if your Piers Morgan, God bless him, he talks about fully transitioned people, and a lot of people who are, you know, not aware of what it is to be trans talk about fully transitioned. And they assume somehow that you start at the bottom of the pyramid, crikey, I'm trans, deal with psychology, what does this mean? Get on the medical pathway, start hormones, have surgery, and pop out the other end fully transitioned. It's not like that, right? It's not so much a pathway, more a meander in the garden, because people need different things at different times. And so when commissioners have tried to commission a service that's a pathway, it's very difficult to give them numbers, because people do need different things at different times. So part of the challenge that pilots have got is to try and make those pathways, those specifications we're given, into something which actually reflects the reality for trans people at the moment. And the pilots at the moment are only focusing on adult services, because that's what they're set up to do. And, you know, you can spend a long time, as I did, knowing that you're trans but not showing it. And for some people, that's all that's ever needed for them. They are happy to know they've got a trans identity and just be perhaps thought of as a little bit quirky, a little bit, you know, not quite as typical as other people might be, and live and die their life in that mode. And for them, that's great. But for some people, things happen and you need to, you know, crack on with it. Younger trans people often have a greater access to information now than I ever had. Back when I was a teenager, you know, the places like the Beaumont Society existed, but you needed to be on their mailing list. You had to, you know, receive brown envelopes with details.
Yeah.
These days, there are multiple forums on Reddit, on Facebook, you name it, and it's much more visible to be trans. So you can acquire.
Is there help there also for parents, for individuals who are going through this? Yeah.
Although to be fair, my parents didn't really much help, you know, on account of my age. Now, if you're focusing purely on younger people, then that's an area outside my speciality. Although I deal with people from cradle to grave in general practice, in the gender side, it's an adults only service. So applying the knowledge of general practice to this, what I can say is, you know, there are people who recognise and let their children flourish in different gender scenarios, and some people who don't. And I don't have a problem with people who don't. I think they're a product of the society in which they live.
Yeah.
They believe what they believe. So if you look at the Western cultures, the Judeo-Christian cultures, quite often people who don't like trans people will say things like, it's in the Bible, Genesis, man and woman, he created them. That's very true. But of course, that's the Judeo part of Judeo-Christian. If you follow the Christian faith, Galatians 22, it says, in Christ there is no north or south, no man nor woman. So, scriptures that serve the purpose that you're going to quote them for. So if you've got somebody who's brought up in that kind of strict kind of way, they may well struggle with their child expressing any kind of gender variance. And sometimes that's a bit repressing for the child. There's often an argument about affirming people. Well, affirmation is really interesting because we use affirmation in safeguarding. The first thing you get taught in safeguarding for children is if a child comes up to you and says, however they say it, I've been, this is a problem. I think I don't like the way they touch me or whatever. What you do is go, okay, yeah, tell me more. I'm listening. What you don't do is, oh, no, they didn't. That's Mr. Jones, the games master. He would never do that. He's trained athletes. No, there's the difference between affirmation and dismissal. And with everybody who's trans, affirmation is kind of the name of the game. You can't deny people's reality just because their reality is different than yours. That's the way it is. And when you look across the world, from trans people, you can go around the globe and look at cultures which have huge histories of support for trans people. So, whether you go for the Fa'afine in Western Samoa or the Mujias in Mexico and Southern America, the complete globe, 3 different kinds of trans people in the Hindu faith. So, we've been there since the ancient priests of ancient Sumeria, the Gaia priests of the goddess Inanna, which is 3,000 years BC. I mean, come on, being trans is not a new thing.
No.
And it just kind of makes me worry about things going on these days when history is denied. So, short answer to your question, there are resources out there for people who are seeking information about being trans and supporting trans people. So things like the Gender Identity Kit, shout out to them because I think they're a great website. There are organisations such as Mermaid, which is national in scope, but in local areas we have on Cheshire Merseyside, we have the Young Persons Advisory Service, we have Sahir House, we have Transport Services, we have the Sea Magic Charity, we have all these people whose aims are to help and assist people who've got gender variance and want to kind of get support. That's what the collaborative part of our Cheshire Mersey Area Gender Identity Collaborative is. It's meaning that at the bottom of the pyramid, that identity bit, that medical bit, and that psychological bit can be brought together in a way that means that we are not, distant and remote as the GICs have been. In a way, gender identity clinics are the ultimate mainframe of healthcare delivery. So obviously I've got a techie background, so I would think in this way. But if you think about how computing used to be back in the old days, you had a mainframe and you would take your program cards to the mainframe, somebody would run them, and then you get your answer. And then personal computing came along and computers appeared on your desks and then on your laptops and now finally in your pockets. And we're all walking around with more processing power than people in the 1950s ever dreamed of, just in our mobile phones. Healthcare, though, has remained on the mainframe for the most part. It's still got hospitals. You've got a tricky problem, you send somebody to the hospital. Whereas if you look at Massachusetts General's ambulatory care practice of the future, one of the things they're doing is saying, well, actually, the world's moved on and we should cloud our healthcare. The people think, if you work in a hospital, if people move services out of hospital, then I won't be needed. Far from it. The reality is, if you move healthcare services like we've done with gender identity into close to the patient, remote in our case, all our consultations are remote. We're digital by default, as you'd expect with my history. So all our people get seen remotely, which is great, as compared to travelling hundreds of miles to go and see somebody in Leeds or Newcastle or wherever they'd happen to find the shortest waiting list. So we're just digital by default. But that digital by default requires a cloud-based support system. So in the case of my colleagues in Manchester, they have a direct monogamous relationship, if you like, with Nottingham GIC. And so any queries, any worries, they go back to Nottingham. Whereas in Cheshire and Mersey, what we've gone for is an open polyamorous relationship, if you will. Our external clinical experts can be from anywhere, because we'll deal with anybody. So, seeking information from colleagues based in Wales, seeking Exeter, London, we'll take that sort of cloud-based knowledge and use it most appropriately. And I think there's lots of areas of healthcare where you could do that. So if you look at the work of Clayton Christensen when he was talking about the innovator's prescription, he lists a whole range of services and specialities which are ripe for this kind of cloud-based approach, where you move the hands-on expertise close to the patient, but keep the knowledge-based expertise in the cloud. And I think if hospitals were smart, they would learn the COVID lessons that a lot of stuff can be done remotely, and do it that way, but some stuff has to be done hands-on. The big challenge is going to be to say, well, actually, the hands that are on don't have to be the rheumatologist's hands. It could be a nurse in a practice, or it could be a clinician in a hub. That means that the rheumatologist doesn't have the patient traipsing hundreds of miles to get seen and sorted. And I think that's one of my challenges for healthcare in general, is how to move health off the mainframe, but move to a cloud without fragmenting the knowledge that we've got in those valuable institutions that we already support.
Excellent, thank you very much. Which sort of has answered my question about what's the future for you, Christine.
The future for me is interesting on a personal level. I'm 57 now, so I figure I've got another 13 years of good NHS work ahead of me. I still run my portfolio career. I mean, I think I had a portfolio career when it was just really a couple of sheets of paper and a wrap around cardboard, and now it's a proper portfolio. So I don't have any plans to really retire or step back. I do want to complete my training as a gender identity healthcare specialist. I'm doing the Royal College of Physicians credential at the moment, so come to the end of that, fingers crossed, November, December time. And then I will hopefully carry on with general practice and gender identity healthcare, and be able to provide some kind of ongoing service, and encourage colleagues to
and hopefully training too.
Yeah, training's a biggie. I think if you look at the figures that came out of America when they were looking at LGBT education in American medical schools, said that they had 5 hours for LGBTQIA. Everything, 5 hours for gender and sexual orientation diversity. That's just not enough, given that 10% of the population may well be part of the LGBT family. So, and within that population, there are specific health needs which are bigger than sexual health needs. I mean, you may well think back to the 80s and how care for gay people was effectively a sexual health thing back in the AIDS pandemic. And look now to good services like the Access service on Merseyside. They run specific clinics for trans people that our team support, because it's the right thing to do, because quite a lot of trans people are involved in sexual health, and for them sexual health can be a really difficult, if not impossible, subject to broach with their GPs. So the future, I think, is advocacy. I think the Economist, God bless them, that's not what I'm really thinking, but the Economist said of the new pilots, their headline was activists, doctors persuade GPs to prescribe hormones to trans people. I'm thinking I'd like that as a citation on LinkedIn. The Economist said to me, I'm an activist doctor. I think, yeah, great, I am. I will have to be in order to make this work, because the clock's ticking.
Well, you have the lived experience as well. You understand and can get.
But my lived experience is a tiny drop in comparison to the people I work with, and you know, colleagues like Tony Griffin, who you know, Tony's got decades of lived experience, and he's the I think he's just stepped down as chair of the See Magic charity. But Tony's lived experience is massive. You know, I just happen to provide a bit of medical, well, 29 years of medical experience, plus a lifetime of repressed gender identity stuff. And it you know, kind of adds to the spectrum of lived experiences. But you know, I'm fortunate in as much as I'm a GP. I've got status from that. So my position as a GP means I get believed by people. Whereas if I wasn't, you know, working as a recognised professional, I may struggle to get taken seriously, and that happens a lot. This is part of you know, when people talk about intersectionality, individuals' identities are made up of multiple different aspects of their life. So, for instance, I used to sing in the church choir. Gender transition made that impossible for me, not because I can't sing, but because I developed a thing called dysphonia, which means that when I try to sing male parts, it doesn't work for me. Sing happily in non-gendered parts, it's just crazy. But that's how voice works, in a way. So you know, being a Catholic, being transgender, being a medic, being you know, a husky owner, was for a long time part of my identity. And when you look at all those things together, at the intersection of each of those things is me. And that's possibly unique. Now, the problem with that is that when you've got that kind of intersectionality of your identities, some of the people you share part of your identity with will have issues. So, for instance, the Catholic Church, God bless them. Catholic Church says that gender ideology, whatever that is a threat to the fabric of society. So simultaneously, I am a threat to the fabric of society. I'm also a GP, which makes me an agent of social control in the eyes of some people. So at the same time as I'm a threat to the fabric of society, I'm supporting the status quo. How does that work out in your brain? Well, the answer is it's stressful. This is the minority stress model, Sandra Bem, 1980, which basically says that if you're from a minority group, and it doesn't matter what minority group, you'll have things close to you that are stressful. So how your family, friends, neighbours, how they react to you as an individual. So if you're the first black person living in your street, there's a lot of minority proximal stress close to you. But if back in the 1970s you were watching Love Thy Neighbour, you may also pick up some stress from the treatment of the characters in that comedy. So that's distal stress at a distance, and that kind of combines to make you feel whether you're valued and safe in society. So if you're a trans person now and you look at the Equality and Human Rights Commission and their latest guidance on the law, it's not the law, it's just their interpretation of it. Quite frankly, in my opinion, it's transphobic. It's been made to be as difficult to be trans as possible. If you look at you know, the fact that on social media there are always people with huge fortunes and vast media outlets take lots and lots of time to have a go at that 0.6 to 1.2% of the population and pick on them because they're visible. We are this decade's mad dog attacks. We're the thing that the media wants to go for. And when it comes to politicians being asked questions like, how would you define a woman? These are dog whistles of immense proportions. Dog whistles, I'm sure you know, it's a signal that somebody sends out that attracts people because it means something to them, but other people will completely ignore it. So, for instance, you know, if I was a famous author and I chose a pen name that happened to be somebody who would formerly, I don't know, run a death camp, for instance, people might think, oh, that's a bit of an unusual choice of name. If I chose it to be somebody who was a big proponent of conversion therapy, people might think nothing of it until I come out as very clearly anti-trans. At that point, anybody with half a light would go, that's what they were telling us when they chose that name. Now, of course, you'd deny it, because you would deny it. You wouldn't want to recognise that you were actually full-on anti-trans in your way of thinking. You would do your best to dress it up in any way you felt acceptable. That the media certainly would swallow, and I think that's the situation we find ourselves in today, where hate crimes are rising for LGBT people, where our national tolerance for diversity in all its types appears to be falling. And, you know, we're supposed to be an open, welcoming country. The fact that as of yesterday, that Safe to Be Me conference got pulled, a bit of an indictment, really. Not just my opinion.
Indeed, thank you for that. I've got some advice here from the Fair Care for Trans Patients, and this was produced by the Royal College of Nursing back in 2017. And it's testament, really, when I was doing my research for interviewing you, there's not a great deal of information there from a research context about the trans community. So it's a testament that we do need more information and more research in this area. And more education within our training as well. So it says, be positive and proactive in your approach to welcoming trans patients in your care. Always treat trans patients in a respectful way as you would any other patient. If you're unsure about a person's gender identity or need more clarity about how they would like to be addressed, then ask politely and discreetly. Avoid disclosing a patient's trans status to anybody who does not explicitly need to know. Discuss issues related to a patient's gender identity in private and with care and sensitivity. And I think you've got a few comments about that, haven't you?
Yeah. There's a few things there that are worth thinking about. Yeah, the education one said about, you know, education for LGBT issues is lacking. The guidance for practitioners, all clinicians, can be you know, hard to find and not necessarily clear. And when you look at how, you know, people access their treatment, it's almost bizarre to me that you can write to a GP and say, you know, we've seen your patient, we're an accredited NHS England pilot, we've done all the right kind of things, we reached the same decision that any GIC would do, would you please consider prescribing the following hormones? And the GP will go, no, sorry, can't do that. I don't feel comfortable to prescribe this treatment because it's off license. Yes, that's right. The reason it's off license is that there is no money in drug companies ever doing controlled randomized trials with trans people. We're too few in number to make it profitable. They've already had these drugs out there for decades. And so going back and putting estradiol gel through a controlled trial now would just be a waste of money. So it's always going to be off license. However, GPs prescribe this on a daily basis for menopause management. They know how this works. It's not rocket science, but some GPs will use that lack of education and support as a means to say, I'm not happy prescribing this. Now, comes back to that bit you mentioned in the RCN guidance about treating people as they would wish to be treated. You know, Sunday school, we used to talk about the golden rule, you know, do unto others as you would have done unto yourself.
Absolutely.
And it's great. It's a brilliant rule. It works really well as long as you and the other person are in the same kind of frame of reference. The catch for trans people quite often is that, you know, if you were trans, you might choose to be he, him. However, the person in front of you, they may choose to be they, them. Now, you choose he, him, they've chosen they, them. What's the way to do it? Treat people like you want to be treated, or treat people like they want to be treated. Clearly, a platinum rule, as it should be, is treat them like they need to be treated. Don't think, actually, this is what I'd want. I wouldn't feel safe with a trans person in my room. I'm a GP, right? I do this all the time. I examine patients, and yeah, of course I get chaperones if it's intimate and whatever. But 9 times out of 10, it's a consultation between me and a patient. I mean, I've got to say, shout out to my patients in Kirby, because when I transitioned, they were just brilliant. They're absolutely brilliant. The funniest one was one of my older patients who's ex-military, and you know, he's a really nice guy, and he sends me a mug and it has on it soon to be Mrs., you know, classic kind of engagement present, or you know, whatever. And it just made me laugh. I thought that is so Kirby, simultaneously having a laugh but actually showing a bit of heart, and that's why I love practicing in Kirby. It's kind of so that guidance is really quite simple. It's treat people like they want to be treated. Don't put your judgment on them. Look after individuals.
Absolutely. Thank you.
I think it's fairly simple, really.
Yeah, thank you. Final question. before we go into any questions out there, if you were to give somebody one piece of advice today who was struggling with their identity, what would it be?
It's going to be okay. That my advice would be, if it's, you know, if it's, what's the Wittertainment thing? It'll be all right in the end. If it's not all right, it's not the end. People just need to keep their heads up and look for help, because people are out there to help.
Thank you. That's good advice. And over to the audience. Have you got any questions? Maddie, do you want to pop your microphone on and ask Christine a question?
Yeah, hiya. There was a few things actually. Sorry, can I start with a fairly easy one and then work my way up? Is that possible?
Yep. As long as it's short and sweet. Thank you.
Yeah, in terms of what you said about not disclosing transgender identity to people who don't need to know, I don't know whether you've experienced it, Christine, but when you're sitting in a waiting room or whatever at the doctor's, and you've asked a million times to have your title changed to Miss or Mrs. or Mrs., and it always comes up MX. The lovely receptionist will change it on the system, but within a week it will go back to MX. And that's a standard thing that I find. I've found it at 3 different GPs now.
Primary Care Support England. So GP systems, part of the joy of GP systems is that they're integrated with the NHS spine. And so the NHS spine is run by an organisation called Primary Care Support England. Now, if you go on their website, they have a really clear flowchart of how to manage gender identity transition issues for trans people. Unfortunately, they don't appear to follow it. And the end result is that the practice can change details, and when they press the go button, it goes off to get synchronized with PCSE's NHS spine. And if they then decide that this doesn't meet our criteria, then the change gets negated and the GP record gets reversed back again.
That's
it's crazy because according to Primary Care Support England, their own guidance, there is no requirement for anybody to have a legal name change for their NHS name to change. So in effect, you can change it, you know, on a whim if you like. But I don't know about you, but most trans people, it's not a whim. It's just people, you don't know how easy you've got it. Your parents, right, had 9 months to think of this, and they had 2 choices to come up with, and then you got that choice. For a trans person, if you're old enough to make your own mind up, you will have endless choices. Do you stick with the old name? Do you pick a completely different one? How do you do it? And quite often in the early stages of transition, people experiment with different names to see how it fits and how it feels. And you know, if you've got a good GP, you can experiment. I had a younger trans person come in and see me, and you know, obviously things can be a bit rough, especially if you're in a rough area where you know, tolerance isn't necessarily forthcoming. And this young trans girl, the next time she came in, and I changed her name on the call-in system, when she checked in as herself, and she was jumping with joy, because this was officialdom, was saying, we see you, you're okay. And that was just the best thing ever. Now, needless to say, how does she feel about that? Fantastic. What does it do to her mental health? Improves it. Hang on a tick, that's my job. I'm a doctor. That's what I meant. Yeah. PCSE, they carry the can for that, because that's how they do. They're well-meaning, right? And I'll give them kind of half an excuse on this one. They're well-meaning because they're concerned that changes to your GP record that then get reflected on the spine could have a knock-on effect in how you get your care. Because, you know, EMIS, one of the clinical systems, as with all of them, they only have one field for sex or gender. And if you change that, then you may not get called for abdominal aortic aneurysm screening. You won't necessarily get thought of as requiring a prostate screen. You wouldn't necessarily get breast screening. You wouldn't necessarily get cervical cytology screening. And trans people of all flavours can require some of these things. So PCSE sometimes think it's doing it, you know, you a favour, whereas in reality, it's just hampering you when you rock up to your GP. Got to say, my GP, not a problem. Didn't bat an eyelid. But then I'm coming at this from the position of being a medic, so you know, it can be tricky.
Is that helpful, Maddie?
It is, yeah. Can I just ask one more kind of brief question? So, both Claire and I are part of a peer support group at NRGDS, and we both involved in the involvement bank as well. NOGDS are currently apparently talking about switching to a similar system as that you had on trial in Merseyside and in Manchester. What kind of advice would you give to kind of push that forward and put it in place?
Good question. I think the approach that we've gone for is to be collaborative. Mm-hmm. So and that collaborative means everybody who cares for trans people. So whether that's the Access Sexual Health Service, whether that's the Liverpool Women's Hospital who deal with gamete storage, whether that's the local medical committee who are effectively the GP's representatives, I've got to say, our LMC is really supportive. Our local commissioners for primary care, the third sector and voluntary groups, support groups such as Spirit Level, See Magic Charity, we getting all those people to say this is what we can do to do this better has been the key to success for us. I'm aware that in other places, local medical committees have been like, well, this is work coming into primary care. And yes and no to that. It should be work that's done in primary care, but sometimes there's a shift of what would have previously been done by specialists. And right now, lots of GPs are on the knees because they do 90% of the work of the NHS with less than 9% of the funding, and we're about 5,000 GPs short. So shifting anything else their way may well feel like the last straw that breaks the camel's back. The approach we've taken is to say, look, we're a pilot, and within the next 2 years, it's going to be 500 plus trans people coming to your door to get prescribed hormones. How do you want to do this? Do you want every single GP to have to learn this skill, or do you want to find in your primary care networks a GP who's willing to get the training to be part of our clinical network to help this bunch of practices and do it that way? Because you don't technically need a trans-friendly GP in every single practice with all the skills. You do need trans-friendly GPs in every practice, but the skills is the bit that you could collaborate across the network. And if you do that, then like we've learned with Trans Health Sefton running since 2017, trans people get a fantastic deal. And what's happened in Trans Health Sefton is that over time, practices have learned from Anna and how she's dealt with trans people. So it's become mainstream for them. She's trained a lot of young GPs who are now old GPs, and they just accept this as the way that you can look after trans people. So taking a collaborative approach, getting everybody in. So look at Manchester, the LGBT Foundation, and my colleague Luke Wookey, who's the lead clinician for Indigo. They pulled a lot together to make that work, and that seems to be the secret to success: is work with the community and all the parts of the healthcare system, so that you can actually take away the bizarre kind of confusions that arise over looking after trans people.
Wonderful.
Is that okay, Maddie?
Yeah, that's wonderful. Thank you very much. Yeah.
Thank you. Claire, you have a question.
Oh, hello there. Thank you. I suppose some of it's kind of following on from what Maddie was saying. So my own experience, Maddie and I are both on the waiting list for NRGDS. My own wait has been 3 years so far. Current timing to second appointment, which is the one that actually starts anything, is I think it's about 4 years from now. Yeah. For me. So and obviously I'm not unique in that. One of the things obviously a lot of us try and do is try to help ourselves in the interim. And you go off and you spend lots of time reading stuff and finding out about all the guidance that's available from the various clinical organisations, NHS England, Royal College of Nursing, GMC, blah, blah, blah. And you give this to your GP and say, can you help me then? And they say no. Yeah. And the more you ask them, the more they kind of dig their heels in on things. Now, I've found that quite difficult because, I was fortunate enough to be able to pay to get some private hormone replacement therapy, but they really don't want to get involved in shared care arrangements. Now, seeing this mention of a recent pilot in I think it was West Sussex that talks about an incentivization model for GPs to help alleviate some of this pressure in this earlier part of the process. And I think, and also, by the way, I am aware that, trans people aren't the only people that have got obstacles getting hormone therapy. my wife is going through the same process, albeit in a completely different way, to get HRT as a cisgender woman, and actually has got the same prescription as me. We have the same bottles on the shelf, but the route to get them is quite different and the cost is quite different. But so I know that there are obstacles in the NHS already for. I'm not sure.
Ignore Alexa. She's on.
I know that there are obstacles anyway for a lot of GPs aren't comfortable with prescribing hormone therapies anyway. But I suppose what I'm trying to do is try to find a way to, even if I can't get my own GP, get the local area to look at these kind of models that are going on elsewhere and try and take them on. Now, as an individual that doesn't work in the NHS, my God, the structure is so confusing. You don't know who the key people are that, to approach, even to say, have you even seen this stuff? And I know from reading lots of stuff locally, because I live in the Tees Valley area, there isn't much information in their plans about trans people. Trans people kind of come up in the we will, we've got a diversity policy that means that we won't be nasty to them when they come in.
There's a lot of stuff there that you're bringing up, Claire. Firstly, the Sussex pilot is still out in procurement at the moment, so it hasn't gone live. What we've had in Sussex are really brilliant forward-looking practices, such as the Brighton Health and Wellbeing Partnership, which has effectively done what you can do within the bounds of good general practice. And that's part of the reason why commissioners want to commission more of a service. You're absolutely right to be frustrated about trying to get something sorted out in every single area. Our rollout of Trans Health Sefton, Trans Health X as we call it, across the patch, I think I've been back to the commissioners on 3 separate occasions, and my colleagues went on the 4th time before we actually got the go ahead. And it can feel frustrating, but the NHS is a big beast, and this is how it works. Part of the challenge that that we offer as clinicians is to say that, you know what, we're doing this anyway. We're going to be looking after trans people. Do you want everybody from Cheshire and Merseyside to move to the likes of the Brownlow practice in Liverpool, which is a university practice that looks after hundreds of trans people, or to other clearly identified trans practices? Do you want that to happen, where you can have ghettos of practices where they don't look after trans people and we know it, or do you want to try and level up so that it doesn't matter where you live, you can get access to healthcare? And commissioners have got a need to do this. However, it's a need set against so many other needs, such as failing the 2-week referral to treat target for cancer. So from the commissioner's point of view, it's in the mix. It just isn't necessarily their top priority at the moment. From my point of view, it's all I have to worry about. So I can spend time talking to the Liverpool Women's. I can argue the toss with the commissioners about why is it that if we see somebody who's trans and we say they need gamete storage, why isn't the money just automatically following that? Why can we not streamline the process? And doing those kind of things, that I get time in my working week to do that.
Yeah.
To take on stuff like this, to sort of point out some of the stupidity that exists around existing systems. But for individuals such as yourself, not connected directly with the NHS, I appreciate it can be frustrating. And right now, the organisations that represent grassroots support are fighting some pretty big battles with, just hanging on to trans people's hard-fought rights to access toilet facilities, to not have to worry. Thanks, Millie. To not have to worry about access to public toilets and access to good healthcare. Just the basics. So yeah, it's a big battle. In some ways, like I say, I've got 13 years left in my professional career. That's what I'm spending the next 13 years doing.
Yeah. Is it really just going to be a case for me then, if I want to try and help build some consensus of opinion locally? I'm just going to have to talk to lots of people until I catch the right one that might be interested in it. Is that?
Yeah. Sadly, some of these things depend on the circumstance and fate. Being in the right place at the right time, saying the right thing in the right place to the right person, being heard. It's part of the reason why I agreed to do this, because it puts it down on record if this is the way things are going, and it's what we need to happen.
Which is the final organisation that kind of says to the GPs, we would like you to do this thing and we'll pay you for it?
That's one of those questions that doesn't have an answer.
Really?
Yeah. It is the equivalent of asking a question with no answer. There is no final organisation that tells the GP to do anything. Part of the joy of being a GP, we're independent contractors. We have a contract with the NHS. The NHS says treat people who are ill or believe themselves to be ill, provide 70 appointments per 1,000 patients per week, deliver on the following quality indicators. The GMC says you should do it safely with regard to good duties of a doctor. The BMA, through the local medical committee, says, hang on a tick, you can't expect people to work when there's no straw to make bricks. This is just crazy. Fights their corner. And the Royal College of General Practitioners says that the good GP would do it this way. And all those organisations each have a stake in how GPs work. And at the end of the day, there is no final way of telling a GP to do anything. Those of us who work in general practice for a long period of time know that dealing with GPs is like herding cats. Now, as a cat person, I know you don't herd cats. What you do is open a tin of tuna. Want to find your cat? Open the tuna. Want to find your GP? Open the tuna. And it's just a question of knowing what the tuna is at that particular moment. The caricature GP says it's money. No, we're at the point now where you couldn't buy extra work out of general practice. It's that bad.
Okay. Oh, well, there's no chance of me moving to Merseyside and getting under your care then.
I hope you don't have to.
Oh, is that okay, Claire? And Maddie's just put a comment in, but unfortunately we're running out of time quickly. She says, is there a feeling amongst trans care doctors that the results of the Helen Webster hearing might change things?
I don't, well, my colleagues for starters, but effectively I don't think that it does. I think if you take the hype and rhetoric out of it, what you've got is if you practice within your competencies, if you practice registered with the CQC, if you practice in collaboration with relevant specialists, then we could do a heck of a lot more in general practice than we currently do. The question is, as I just said to Claire, have you got the resource to do it and the aptitude to take it on? And the bottom line is, at the moment in general practice, there's just not enough GPs, and there's so much work since Freedom Day. It's crazy. And can you make it balance? Possibly not. The actions of an individual GP who tried their best to provide good services to trans people, and the subsequent GMC dealings, that's not a big impact in my view.
The thing is, it's important we need to talk about it more. I think that's the thing. Christine Mimnagh, you're officially a fab hero. Thank you so much for agreeing to talk in our first Fab Talks. As people who know me, I like to finish on a quote or a poem. So I have a poem. This isn't particularly about trans. This is for everybody who's going for a struggle in life. And it's called Never Give Up. Never give up, never give in. Move onwards and upwards with strength from within. Always believe. Always look forward, never be the one who is seen as a coward. Remember the past, look for the future. Always remember it's often good to be obscure. You are special, you are unique. To go far in life is what you should seek. You are brilliant, you prove to be amazing every day, and there is someone who will love you in every way.
So if I'd have been cheeky, my poem to reflect back would have been by Jay Hume. I don't know if you know Jay. He's a 25-year-old trans man doing well in the world of poetry, and his latest book, The Backwater Sermons, has a fantastic poem in it called Jesus at the Gay Bar, and it goes like this: Jesus at the gay bar, he's here in the midst of it, right at the center of the dance floor, robes up, hitched to his knees to make it easy to spin. At some point in the evening, a boy will touch him, the hem of his robe, and beg to be healed, beg to be anything other than this. And he will reach his arms out, sweat, damp and weary from the dance. He'll cup the boy's face in his hand and he'll say, my beautiful child, there is nothing in this heart of yours that ever needs to be healed.
Thank you so much, everybody, for joining us today. My name is Vanda Carter. Thank you. Our next Fab Talk will be on April the 20th, 5 till 6, with the fabulous Chris Poynton to talk about My Name Is campaign. Thank you so much. Nice. Thank you again, Christine.
Bye-bye.